right, good afternoon, everyone. My name is Ritika Frappa, and welcome to our last Yale Sleep Seminar for Fall 2023, although we still have one joint conference left. And before I introduce our today's speaker, I'd just like to make a few brief announcements. Please take a moment to ensure that you're muted. In order to receive CME credit for attendance, please see the chat room for instructions. And if you have any questions or comments during the presentation, please use the chat room or take the opportunity to unmute yourself at the end of the talk and ask questions, and I will also moderate the sessions. Recorded versions of these lectures will be available online within 2 weeks at the link provided in the chat. And now I have the extreme pleasure and honor of introducing our today's speaker, Dr. Lisa Wolfe. Dr. Wolfe received her medical degree from Ohio State University. She then completed her internal medicine residency and her pulmonary critical care and sleep medicine fellowship from Northwestern University, Chicago. She's currently a professor of medicine in pulmonary and critical care and neurology at Northwestern University, Chicago, and the medical director of respiratory care at the Shirley Ryan Ability Lab. Her research has primarily focused on the use of home-based non-invasive ventilation, specifically the development of advanced modes of ventilation that target the care of those with neuromuscular disease-related hypoventilation, central sleep apnea, diaphragm dysfunction, and COPD. She has also directed and designed multi-center clinical trials in neuromuscular-related hypoventilation. Dr. Wolfe has lectured in courses in sleep disorders mainly related to non-invasive ventilation nationally and internationally, and has contributed significantly on education in this field. She has also been designated as the Distinguished Chest Educator multiple times. She's received many awards, is a recipient of several grants, including from the NIH, and has authored many publications, book chapters, practice guidelines, including the most referenced paper on initiation of NIV for hypoventilation on chest, and recent guidelines for the respiratory management of neuromuscular disease patients. Dr. Wolfe has also held leadership position in many national societies and committees, including the ONMAP expert panel. Thank you so much for being with us, Dr. Wolfe, and your time. And without any further delay, I would like to hand it over to you to share your expertise on non-invasive ventilation for hypoventilation.
So thank you so much, Shri, and thank you for inviting me. I love you guys. Shri, what I want to know is, did my mother pay you to say all of that? Because that's pretty awesome.
Well, you don't know about that, so we'll keep it secret.
Yeah, exactly.
And let me share my.
So if you could start by sharing screens, we're having some technical issues, so I'm actually on my phone today. And so we're going to talk about non-invasive ventilation and strategies for patients with hypoventilatory syndromes. So next slide. I really don't have anything to disclose. And then for an outline, we're going to talk about lots of different areas of hypoventilation: central apnea due to narcotics, neuromuscular diseases, obesity, hypovent, COPD, and phrenic dysfunction. So next slide. So I want to start by going through a case in a patient that has a history of C-spine injury. And in this case, the C-spine injury is in association with multiple sclerosis and white matter lesions within the C-spine. And this patient is noted to have a high level of baclofen in their system. With baclofen, just something for you guys to watch for. Frequently, our patients have baclofen pumps rather than just getting oral baclofen. And because of that, it doesn't get put in the MAR. It's not in their electronic medical record. And so you'll be like unaware that the baclofen is there. So if you start seeing profound centrals in someone like this, you have to go back and see if they're getting their baclofen as a pump. And then the other thing is that he's getting Norco. Norco would be, as a narcotic, in narcotics in general, the most common cause of central apnea. And you'll see that within the polysom that is the little fragment is there, that the central apnea events are occurring predominantly in non-REM sleep. In REM sleep, they completely go away. And you'll notice in the labs that the serum bicarb is very low. It's at 22. So these are the hallmarks for patients who are going to be at risk, specifically for central sleep apnea due to hyper or overventilation, and are seen in patients that have Cheyne-Stokes physiology. Next slide. And this is just a fragment from this patient's polysomnography. And you can see here the waxing and waning with hyperventilation in association with central apnea events. And what's also super interesting about this, you see the leg kicks there? So this guy's quadriplegic. And so the first thing you would normally say is, my God, how is it that he can kick his legs? I can tell you that when awake alert, this guy cannot voluntarily move his legs at all. And so I love little snippets like this in my quadriplegic patients, because what it reinforces is that periodic limb movements can frequently be spinal reflexes and disconnected from what we typically think of as central brain issues with ferritin. So just an interesting little tidbit. Next slide. And so what you're going to see here is that this patient was given adapt servoventilation rather than given ST or VAPS. And the reason for this is that in this setting where the disease is generated by drugs that we know are a problem, and in the setting where the C-spine is involved, because we know that the C-spine causes loop gain dysfunction, and that's probably due to impairment of the superior cervical ganglion, which is at that C4 level, and because the events were predominantly non-REM in nature. And what you'll see here is that this patient was given a fixed EPAP of 10 with pressure support in an adapt servoventilation mode. And for those of you who haven't seen that, we're going to see it 2 slides from now. And what you can see now in this little snippet from the polysom is that the sleep disordered breathing is completely resolved. And what you see in addition, if you look towards the other side of the screen, is that there is something called a CO2 gap or an apneic-eupneic threshold. So this is the difference between where your CO2 sits right now and where your CO2 sits, so that it would be so low that you'd have to have a mandatory central. And because the bicarb was so low in this patient at 22, that CO2 reserve or that CO2 gap was very, very short. And so that's how we get into the issues that we're seeing here. Now, there's a suggestion in this reference from 2015 that we would have been better off with auto EPAP rather than the fixed EPAP that you're seeing on the screen. So can I have the next slide? Maybe. There it is. So what we're seeing is that in the ASV devices that were initially put on the market, they used that fixed EPAP that you saw in our previous slide. And those were set up based on the highest documented EPAP necessary to address critical opening of the upper airway. And like we see in most patients with obstructive sleep apnea, that's likely during supine REM. But the problem is then during non-REM sleep, or when they're side sleeping, that's going to give you an EPAP overshoot. And the problem with EPAP overshoots in these patients that have loop gain dysfunction, that have very small CO2 gaps, is that it will get them into a position where they will have even more centrals, not less. In addition, there's something called the Herring-Brewer inflation reflex, which is that if my EPAP is over the critical opening pressure of the upper airway, you get additional stretch onto that pleura, and that response to the stretch includes a central apnea event and an arousal, both of which are going to worsen sleep, not improve it. And the other thing is, although it wasn't a factor in our patient, the lower the preload, because the EPAP is too high, can be an issue in patients who, say, have pulmonary hypertension. And then in the current devices that we have, They use an auto EPAP with an EPAP min and an EPAP max range, which then tracks as the peak crit changes, and we get much more effective settings for these patients using these advanced devices. Next slide. Okay, so ahead of the setup of an ASV device, you should realize that they're only available in RAD devices. In other words, none of the home mechanical devices can do this for you. Know which brand of device you're using, because in the ResMed devices, you really can't access the backup rate, whereas in the Respironics devices, you can. And the generation of software with the auto EPAP should be available on all devices, but you have to make sure and engage it. It's not going to just be there unless you turn it on. And then also make sure, as we said before, that you check the sleep study yourself to convince yourself that is Cheyne-Stokes respiration, that it's non-REM dependent, and look for underlying diagnoses that can be driving this, such as HFpEF, AFib, Shy-Drager, MSA, and also pulmonary hypertension. And in this case, the one that we just saw, it's the drugs like baclofen and narcotics, but also to make sure that you don't have such high level of diuretics that it may be driving changes in the CO2 that can drive these centrals. Next slide. And for those of you who have not seen this before, and I'm assuming we've got a bunch of sleep fellows on the call right now, what you'll see is that the waxing waning of the respiratory hyperpnea that's seen with Cheyne-Stokes respirations, in the adapt servoventilation, it's the mirror opposite image so that the CO2 buffering can appropriately take place. And you can see that in the figure above. But also the other thing to remind you guys of is the presence of a pneumotach. And for the fellows that are on this call, I have been reminded several times in the last month that our fellows, even our pulmonary fellows who have gone through a full pulmonary fellowship, don't understand what a pneumotach is. And so what you're seeing here is that there's an air column, and as the air goes through the column, a pressure transducer is set with a screen which acts as a filter in between the two pressure changes. And that allows us to use Boyle's law so that we can estimate both volume and then ultimately flow, so that we know when inhale is happening, when exhale is happening, what's the minute ventilation, what's the size of the breaths. None of this software would work without the pneumotachograph. And so it's important for me to just throw out there that it's an important part of this technology. Next slide. And the other thing is that because the pneumotach has to effectively understand what's going on with airflow, you cannot have a ton of leaks. If you've got a lot of leaks, the ASV software and all of the software that we're talking about won't work correctly. So I just wanted to remind you of a couple of things that you need to do to reduce those leaks. You know, we always talk about things like trimming beard hair and considering a full face mask. But in reality, the full face mask can be a problem because if you pull the straps too tight, the jaw gets thrust into the back of the throat and can actually make obstruction worse. So instead, some of the things that we use that's a little out of the box thinking is a hose lift, because the hose lift, which you can see on this slide, reduces the movement of the mask and therefore reduces leak. Because the tubing itself is so heavy that if you don't do that, the heaviness will pull the mask off. And then my other favorite is the mask stabilizer, which you're seeing in the picture with the head on it. This is not the same thing as a chin strap, because with a chin strap, it would go to the top of the head and it would potentially help to lift the chin, but it also may throw the chin in the back of the throat the same way tightening the straps on the mask would. What happens with the mask stabilizer is because it literally goes under the chin, it does essentially jaw lift, chin thrust, the same way you would have done in your basic life-saving class, which is the best way to both keep the mask in place and keep the upper airway open. Always start the flow of air first so that the silicone pockets that the mask is riding on will form fit to the face. If you put the mask on first, that all collapses, and then you have to tighten the mask, and that causes its own problems. Okay, next slide. So then if I have this patient that's on their ASV device, how do I assess whether or not I'm effectively treating them? So I'm going to introduce to you guys this concept, which is relatively new, but I think is super important for you to think about, which is that we know that the term apnea-hypopnea index refers to events as they are scored in the gold standard polysomnogram. And if we look at something like a home test, we call it the REI rather than the AHI, right? So a respiratory effort index. But if we're getting these numbers off of a machine, we should refer to it as the AHI-F or the AHI flow. And the reason that that's important is a couple of things. One is that the AHI flow is generated without knowing whether or not you have desaturations, so frequently overestimates what's going on. And specifically in devices that are using backup rates, like the devices we're talking about today, the AHI flow should only report events that were not adequately treated by the backup rate. And so in old versions, like of the Trilogy, they used to report every time the backup rate was used. And you'd have these AHI flows of like 100, which was ridiculous. The newer software has now taken care of that, and the AHI flow should more accurately refer to what's going on. And then, yeah, so that's all there. Okay, great. Can I have the next slide? And it's really important to know that we define periodic breathing as greater than 3 breaths in a 3-second period. I'm sorry, in a 20-second period that are separated with those 3 seconds. And it should be 0 because there's no time at which periodic breathing is acceptable in adults. In children, it can be normal to have periodic breathing, especially when they're infants. But it is something that you should look at when you're looking at your efficacy download. And the AHI flow may be higher in patients where there's flow limitation. So you want to see whether or not it's a flow limitation or a true apnea. Okay, next slide. Okay. All right. So so we talked about how to set this up. And when you do the setups, then you should just let the machine do auto backup rate. It's the only time I'm going to say yes to auto backup rate is with those ASV devices. Otherwise, you want to set that yourself. And that's one of the big differences between ASV devices and VAPS devices. All right, next slide. And we've already talked about CO2 reserve, but the reason that I wanted to show this is that this slide specifically looks at the CO2 reserve problem in spinal cord issues. And what you see is that if you expose somebody with a spinal cord injury, which is sort of the gray area on this graph, they overventilate. And so you see that their CO2 reserve is a lot smaller, whereas in patients that have functioning superior cervical ganglions, they don't have that problem with a really small CO2 gap. Next slide. But if you look at this, you'll see that in other patients like neuromuscular disease or obesity hypovent, that gap is extra large. And because it's extra large, we're going to have to look at a different device for them. And that would be a ST or a backup rate or a VAPS device. And the reason that you want to look at a different device for them is because their resting CO2s are so high. I just want to emphasize this because I see way too much of patients with neuromuscular disease getting an ASV when really they should be on a different device. Next slide. So if you're going to be doing the download on this ASV patient, check your PSG to make sure that it's the right device. Take a look at your compliance, take a look at your mask fit. Then for efficacy, you're going to look at your AHI flow, make sure that your EPAP range is where it needs to be. And then if you're still having problems with very high AHI flow, then you may want to consider changing your ranges. Okay, next slide. All right, so we've actually been through these already. Go through the next slide. Okay, so now we're going to look at a case that is a neuromuscular case. So this is the 61-year-old who has a history of a spina bifida with a Chiari malformation and scoliosis. And you'll see here that she had spirometry done that showed a vital capacity less than 50%, and that her maximum inspiratory pressure was minus 37. Now, for that patient, those lung functions already qualify her for a PAP device. However, she was initially put, for reasons that pass my understanding, not done here, on a VPAP auto device. Now, the VPAP auto is the worst named device ever, because when you hear that term VPAP, you think that the auto is there to help with ventilation. But that device, the VPAP auto or the BiPAP auto, actually is only looking at obstructive sleep apnea. It's not looking at anything else. And so what you'll see here is that in this patient, her central index starts to elevate and it becomes problematic. But the bigger problem is that her exhaled tidal volumes are very small. Here you can see it's 275. And if we take a look at the respiratory rate divided by that exhaled tidal volume, we get a rapid shallow breathing index of 58. Now, what I want you guys to think about, and this is like a new kind of way of thinking about this, is that the rapid shallow breathing index that you're used to asking only is a patient ready to be extubated. That's not what it's really looking at. It's looking at how much effort are you having to make to breathe. And when the PAP machine is on, we want the patient to be at rest. We don't want them to have to make any work in order to breathe. And in that case, we'd like the RISB to be low. So it's the opposite of what you see in the ICU. And we'd like to see it under 40. And here it's very high because the tidal volumes are so small. Okay, next slide. Oh, and there it is. There was the data for that. So what you'll see here is that when we did the sleep study, we looked for respiratory effort and we used alternative monitors, including monitors for accessory muscle use. And what you're seeing here, especially in the pink, and then the blue is nasal ali, so twitching of the nose, and genioglasses here. And what you see is that there's increasing effort to breathe, but the patient is unable to trigger the breath at that point to get the breath they need. And that dyssynchrony is going to mean that you're not getting proper ventilation. All right, next slide. So what we did for this patient was we used the IVAPS mode, which is intelligent volume assured pressure support. We did it with a RAD or a bilevel PAP device so that we could do it very cost effectively. And in some of our hints to getting this set up, because I know one of your main objectives for this talk was to understand how we physically get this stuff set up and going. Don't use the learned targets. Learned targets means that the device would learn ineffective breathing, and we don't want that. We want to actually give more support than the patient's able to generate on their own. And because of that, we're going to target alveolar ventilation to give us a tidal volume close to 8 cc's per kilo. We're going to give ourselves a nice pressure support range to do that, and a very low EPAP, because they really don't need that. But what's very important are what's dubbed the comfort settings. And these are more than just for comfort. Specifically, the inspiratory time minimum is set longer than you normally would. So we have it set at 1.2. We also have the trigger set very high, meaning that it's highly sensitive and it'll give you a breath with even just a little bit of air movement. And the cycle is set very low, meaning that the breath won't end until there is very, very low or almost non-existent flow. And the rise is at 300, meaning the patient gets that breath quick. It's almost a square wave. And that's what you want, because the patient shouldn't have to tug to get that breath. If you ever hear a patient say that the machine is suffocating them or drowning, it may be because the rise is so slow that they don't get the breath as fast as they need it. Now, we're going to have some graphs to show you this in a little bit. The other thing that I would tell you that is sort of one of our rules of thumb, if you see the shoulders rising, it means that the rise itself is set too slow and you've got to turn it down. Okay, next slide. If remember last case, I showed you guys how the ASV was the mirror image of the patient. So the VAPS is the opposite of that. In the VAPS, which is what we're looking at now, it's actually escalating tidal volumes so that we can overcome the problem that the patient has in terms of having breaths that are insufficient. So that the ASV and the VAPS are the opposite of each other. The ASV is for the overbreathing patient and the VAPS is for the underbreathing patient. Next slide. And if you're looking at the device ahead of time, it's important to know that in VAPS technology, you could get either a RAD, which is like a BiPAP machine, or a vent. And in the first generation of RAD devices, they only had fixed EPAP. But to get to the second generation where auto EPAP is present, you actually have to get to a full ventilator. Now, this is true in the US. If you go to Europe, however, you can get auto EPAP on RAD devices, but not yet available. And I don't think anyone is bringing it available to us very soon. So that if you need that auto EPAP, you're going to have to get a full vent. This polysomnogram is most often not needed because the VAPS technology allows us to get where we need to go, especially if we're using auto EPAP. And the criterion are neuromuscular disease patients or scoliosis, that they have a low FVC or MIP, a high CO2, or significant hypoxemia. And it's any one of those. You don't need all of them. But for the vent, it's really easy in that you really only need to show the hypercapnia, and you don't have to get full spirometry. And for inpatients, that makes a huge difference. Next slide. And if you're looking at an IVAPS machine, first generation, basically a BiPAP device, there's going to need to be a calculation for something called a targeted alveolar volume. And that's just not something that's very easy to calculate because, you know, the dead space and the whole business. So what you would do now is just go into your Google or whatever you're using for your search engine and put in ResMed targeted alveolar volume, and it will bring up a calculator for you. And all you have to do is put in your patient's values, like their height, how many cc's per kilo you want, and then it'll make the numbers for you. In the old days, it was tough because you had to do that with a machine in front of you. But now that the software is easily available online, it means that making these estimates is a lot easier. And then if you look at the second generation devices, if you look at the second generation devices, you could use a targeted alveolar volume, a safety tidal volume. But to do a safety tidal volume, and I don't know if you guys are doing this, the problem with it is that it doesn't escalate fast enough. And so we'd rather stick with doing the targeted alveolar ventilation, even if we're going to look at using a device that is a RAD. Okay, next slide. Okay, so we've seen that graph already. Okay, next slide. I'm sorry about that. I put it in twice. All right. Now, if you're setting up an IVAPS device, when you do it, you're going to do it differently for COPD and for neuromuscular diseases. In COPD, you want to keep the EPAP range at its full range because it can help with patients that in the US are most likely to have some obesity, and it also helps to reduce air trapping and auto peak. You want to keep your TI min relatively short because that will help to give you time to deflate, but you still want to use 8 cc's per kilo as your target, as that has been shown to get us to IPAP levels where we're going to get at high intensity. And our next case, I'll show you how high intensity works. For neuromuscular patients, it's very much the opposite. You don't really need to have a full range of EPAP. You want to keep it just super low at like 4. And your TI min needs to be long so that you can do lung volume recruitment. And if you're going to use an AVAPS machine as opposed to an IVAPS machine, the most important thing is that COPD should be done in ST mode, where, as neuromuscular should be done in pressure control mode. Sri, what kind of machines are you guys using in your lab? Are you using IVAPS or AVAPS? Okay. You have to come out to answer.
Yes, mostly AVAPS and sometimes IVAPS. Yeah, we
Do
mostly
you
do
have
it.
both devices?
Yeah.
Okay, so if you have both devices, that's great. It's one of the reasons why I have this set up so that on one side of the screen you have one device and on the other side of the screen you have the other device so that you can learn how to interchange between the two. Okay, next slide. All right. Oops. Hold on a second. Okay, so the other thing is when you're looking at compliance on these downloads, I just wanted to throw this in the neuromuscular case, because one of the things that we see in neuromuscular patients is if their compliance is super, super high, 12 hours or more, there's 2 things you need to watch for. One is that at 12 hours, we think about getting a secondary backup device. We also think about adding mouthpiece ventilation, which isn't on my talk today, but it's something you should think about. And then lastly, if the disease is rapidly progressive, like an ALS patient, once you have these super high compliances, like 12 hours or more, is when you might want to start talking about enrolling in hospice. Okay, next slide. And the other flip side of this is the low side of compliance. And it's super important to know this classic slide, which is a study of ALS showing that if you can get the patient to use it for more than 4 hours, their survival improvement can be more than 10 months greater than people that don't use it. And I can tell you right now that that benefit, that 10-month benefit, is better than any drug that's available for ALS. And the same thing. Using NIV at least 4 hours has been shown to reduce the cardiac issues in Duchenne muscular dystrophy. So really that strategy to get the low patients to use it, more important than if we're looking at, just straightforward OSA. So next slide. What else? Oh yeah. So these are just a couple of other things to help reduce your mask leak. The biggest difference here is the shelf liner paper. And if you guys are asking why I have shelf liner paper on this slide, it's because you'll see that the patient who's here on this picture has really thin, almost baby fine hair, and the mask moves around a lot because of the baby fine hair. So what we do is we take little strips of the shelf liner paper and glue it into the inside of the mask, and it stabilizes it so it doesn't move around. Next slide. And oh, this is the other thing. In neuromuscular patients, when you're looking at interpreting their downloads, efficacy is not defined by looking at the apnea-hypopnea index. That's really there for central apnea or obstructive apnea. In our patients, we really want to look at the minute ventilation, the tidal volume, the respiratory rate, the RISB, because what we really want is good ventilation. So make sure to look at ventilatory factors and not just apnea-hypopnea index to mark efficacy in these neuromuscular patients. Next slide. And this is a little study that we did a while back where we looked at how well the IVAPS works if you add the auto EPAP to it. And what you can see here is that in our neuromuscular patients, if we use the auto EPAP, not only do we see an improvement in their apnea-hypopnea index, but we also see a significant improvement in their CO2 and reduced CO2 outcomes. So it's something that we feel like in neuromuscular disease should really be considered. But again, in the US, you have to go to a full vent to do that. Okay, next slide. This just goes through what I already talked about. So next slide. And this is just emphasizing the work of breathing issue, which is that we want to keep our patients' work of breathing low. And you have to look at both the frictional work and the elastic work in order to understand that. And if we're going to look at both, what that says is that we need to have decent tidal volumes in order to reduce that work. And there's a lot of reasons for it. One of which that's super important is the relief of basilar atelectasis. Okay, keep going. And here what you're going to see is that if we get that adequate tidal volume in there, and if we get rid of that atelectasis, we're going to find that the not only do we have an improvement in work of breathing, but we also are going to lower fatigue and make the patients more comfortable doing more work with less effort. And that's really important in ALS. Okay, keep going. This is just making that same point. The only thing that I would also say is that the reason that I have the guy there, like lifting up the weights, is because in neuromuscular disease, it's when you have a fatiguing muscle, that fatiguing muscle fatigues not by stopping to try and do the effort, which would be an apnea, but by failing to complete the effort. And that is a problem with spontaneous cycle. And so that's one of the reasons why the TI extension is important and why it's also important to look at the percent spontaneous cycle. Next slide. And so what you're seeing here is our ALS patients from Northwestern. And you'll see here that if we increase that tidal volume up to the level that's at about 8 cc's, our F over VT, or our work of breathing, goes down the lowest to under 40, which is our goal. Next slide. And Let's see here. We've already talked about this. Next slide. Okay. Next slide. Sorry about that. Okay. All right. So this is a really important thing to look at in these neuromuscular patients. What happens is that if you just look at complaints, so this is the ALS FRS score, which looks at respiratory complaints of patients with ALS, their work of breathing could still be all over the place. And so the only way that you're really going to know where your patient is at is to get full spirometry and or overnight testing and or polysomnography so that you can initiate non-invasive ventilation at the right time. Next slide. And the other thing is, after you have your patient on non-invasive ventilation, and we're still talking about neuromuscular disease here, what we find is that if you have NIV effective, meaning that the O2 saturation is greater than 90% for greater than 90% of the night, that what you see is an improvement in survival. So what we see is that if you're in the red group, your survival goes down. And if you're in the blue group, your survival goes up. But what's most interesting is that if we do a full download off of these VAPS devices, and we include an estimate of hypoxemia with them and then make adjustments, right? We turn them up, that they can transition from red to blue and their outcomes change. So it's worth it to do this. Now, why am I bringing this up? And we can certainly discuss this after, is because we are now using our HST devices, especially the WatchPat, so that we can monitor our neuromuscular patients at home while they are on their NIV, so that we can get an idea of where they are at in terms of that oxygen saturation level while they're using their device. Okay, next slide. And so then in summary, what this reminds us of is that if you're going to be setting up a patient on VAPS technology and they have neuromuscular disease, know which machine you're going to use, decide whether it's going to be a RAD or a vent, screen them for high versus low compliance, make sure that you've done everything to fix your mask fit problems, take a look at your efficacy by looking at tidal volume, respiratory rate, and RISB. And if you are there, great. But if you're not where you need to be, increase your pressure support, increase your TI min, do the monitoring to look for whether or not you're hitting adequate minute ventilation, and do overnight oximetry if you can in order to make sure that you're hitting your targets. And if you're not, consider other things. They could be having PEs, but for the most part, we want to make sure they're hitting their ventilatory goals. Okay, next slide. So the next thing that we want to talk about, next slide, we've already talked about that. Okay, so the next thing that we want to talk about is obesity hypovent. And in patients with obesity hypovent, this is a patient who was admitted to the ICU with increasing lower extremity edema and profound daytime sleepiness and lethargy. And they were found to have a high BMI, and even on oxygen, they had a hard time getting to adequate oxygen saturation. And the right diaphragm was elevated due to hepatomegaly, not due to diaphragm dysfunction. And they had signs of pulmonary edema. Now, the reason that I'm bringing this up is that the vast majority of our obesity hypovent patients who are admitted to the ICU are admitted there with secondary issues with either pulmonary hypertension or HFpEF. And it will make it more challenging to ventilate them. Here you find that on their blood gas, they have hypoxemia, but also hypercapnia with a CO2 of 67 and acidosis with a pH of 728. And this is chronic because even if you look at their labs, the CO2 is elevated to 37. So this isn't something acute. What's interesting is that they've been aggressively diuresed, and you can see that because the chloride is down to 91, and that might be causing a closing of that CO2 gap. And as that CO2 gap closes, it means that this patient is at risk for developing both hypoventilation and central apnea. So next slide. This is just a reminder for fellows, because this is going to show up on boards. The reason that these guys get in trouble is as the BMI elevates, the FRC and the ERV go down significantly as a mechanical factor from chest wall and abdomen. Next slide. And so this is a slide that sort of, I think, is a really important point when we start to understand both obesity, hypoventilation, and quite frankly, neuromuscular disease. So if you look at a lung from a patient with severe obesity, like the one that we just showed, for the most part, they're going to have significant atelectasis at the base and then more open lung at the top. And typically what we would do if you just increase the pressure support is that you might overdistend the good lung without ever recruiting the bases. And that's usually because the patient's very tachypnic and it requires a lot more time to get to the base. And the little sort of formula that's at the bottom of this slide highlights the fact that one of the biggest fairy tales we tell our trainees is that tidal volume is proportional to IPAP minus EPAP. And it's not that that's not true. It's just there's a lot more to the story. The more resistance there is, the less important that factor is. And we know that there's resistance due to the atelectasis and due to the issues of chest wall and abdomen, as we saw in the previous slide. And in our patients with obesity, we also get into trouble because the IPAP minus EPAP is limited because you max out. You either max out because the pressure is so high the patient doesn't tolerate it, or you max out because the pressure is so high the machine has nowhere else to go. And if that's the case, the thing that makes the biggest difference is adding an expanded or lengthened inspiratory time. So just like we did with the neuromuscular patients, in these obesity patients, if we both increase their pressure support, but also simultaneously prolong their inspiratory time, we're more likely to recruit that atelectasis, giving us a better open lung model, improving VQ mismatch, and ultimately both improving oxygen saturation, but also improving our CO2 levels. Okay, next slide. And this just emphasizes two things about doing that. One is that the area under the curve of a pressure time curve is giving you the exact tidal volume. And so prolonging that inspiratory time allows you to augment tidal volume if you look at a pressure time curve. And then the other is that if we look at end expiratory lung volume and peak crit, we see that the better the end expiratory lung volume, the lower the peak crit. And that's that final graph that's on the top there. And so what that means is that if we prolong the inspiratory time and improve the end expiratory lung volume, then what happens is that you can drop your EPAP because the peak crit is better. And now the I minus E difference is much better. And you have a better ability to ventilate because you haven't reached that ceiling in terms of pressures. Okay, next slide. And what you're seeing here is that in patients with obesity hypovent, if you give them oxygen because you can't get them ventilation for whatever reason, it really increases their mortality. It increases hospital readmissions. And it suggests that there is either a disease you're not treating or the fact that you just haven't looked at your CO2, and by adding the oxygen, the CO2 is just getting worse. And we know that this is a problem because higher CO2s in our research environment cause an increased risk for infection, especially lung infection. And the research labs here at Northwestern, my partner Kalila Gates has shown that this increases risk for both influenza and Pseudomonas. And on top of that, Yasha Schneider in our department has shown that if you increase that CO2, you get myopathy induced even in normal healthy muscle, which makes the ventilation even worse. Okay, next slide. All right, now this is a series of cartoons that helps to describe how we are going to ventilate these guys better. Now, I'm going to go through it with you really quickly just because I don't want to run out of time here. However, if you are fellows and you want to get a better sense of this, the AASM has a thing called Choosing Sleep. And they're a set of lecture videos that are on Vimeo. And you can just go on there and look at the one on VAPS under my name, and it has all of the stuff I'm going to show you right now. And I highly suggest going through the video because this stuff is not straightforward and you're going to have to go back and forth a couple times. All right, so give me the first arrow down here. So what you'll see is that there are two kinds of breaths on these ST devices. Some of them are triggered by the patient. Others of them are just delivered by the device because the patient's apneic. Next arrow. You will see that in a ResMed device like this one, there is something called a cycling window. Your breath cannot be shorter than the TI minimum, which is the beginning of the window, but it can't be longer than the maximum. In a spontaneous breath, like the one in front of you, you'll see that the breath ends somewhere in the middle of the cycling window. But on a delivered breath, because the patient's apneic, it just goes to the TI min and it stops. Okay, next one. There's the TI min. Next one. Now, what you'll see is that this helps to even out the tidal volume or the area under that curve because this is a pressure time curve. That means that if you're a neuromuscular patient using ResMed ventilation, you're not going to have problems with big breath, little breath, big breath, little breath. And you'll see that in the Respironics style, that can be a problem. Next slide. In a patient with obesity hypoventilation, we also have the option of putting that type of ST mode together with a VAPS target and auto EPAP. Now, the auto EPAP is super important in obesity because of three things. Number one, remember our case. These guys come in with HFpEF. Fluid shifts are a huge problem for them. The more you diurese them, the less edema you have in the neck, the less your peak crit and the less EPAP you need. And that's going to change night to night. In fact, it's going to change throughout the night because of something that we like to call the wine bottle hypothesis. Sometimes we call them just rostral fluid shifts. And basically what happens is that if you have terrible edema all day and then you go to lay down at night, all that fluid runs up. And that fluid running up causes two problems. One is that it swells the upper airway, but the other is that it increases the pulmonary hypertension and can drive more central apnea. So having an idea of where you need to be best treating obesity hypovent, especially in these acutely ill guys, means that we're going to both target a tidal volume, target an or an alveolar volume, depending on which device you're using, but we're also going to do auto EPAP because it's going to change so much. Okay, next. Now, especially for our fellows or anybody that's going to be taking boards, this is one thing that I can guarantee you is going to show up. And this is the statement from the American Thoracic Society on the treatment of obesity hypoventilation. And I got to tell you, this document is super thick and difficult to get through. But if you're going to do one thing, I would suggest looking at this graph because it tells you what to do. The problem is the graph itself is also a little bit difficult to get through. So I have it summarized on the next slide in something that I call the step up, step down method. So can you get me to the next slide? Okay, so step up versus step down. looks at the difference between inpatients and outpatients. In an obesity hypoventilation patient who's an outpatient, they are going to start with CPAP and they are going to step up to more sophisticated therapy, going to bi-level spontaneous, bi-level with backup rate, only if they fail the device before. If you look at inpatients, so that's the case that I just showed you guys, it is going to have a step down method where we start them with VAPS AE and some oxygen. And after about 3 months, we will know that the fluid shifts are going to be stabilized, and we should be able to bring them into the sleep lab and step them down by going to CPAP and seeing if we still need a step up. So it's important to think about the difference between these two patient groups. I know that there are a lot of people who would say, I don't know why I have to give a backup rate at all, that these central apneas will just go away, quote, on their own. But it's important to remember that in obesity hypoventilation, there's a lot of autonomic dysfunction. And so they're not like the average patient, and it's worth it to give the backup rate. Okay, next slide. Okay, so here's where we're at. We have like 1 minute, right, Sri?
That's right.
So I don't want to go to the next 2 cases. I have 2 more cases for you guys. One is COPD and one is Parsonage Turner. But since we've only got 1 minute, I think that if we could stop for just a couple of questions, maybe we'll just say, hey, we did neuromusc and we did obesity and central apnea, and maybe that's enough for 1 lecture.
I think that's correct. And we do have Dr. Krieger's lecture at 3 p.m. So if folks want to leave, I think that's fine. But thank you so much, Dr. Wolfe, for this excellent and very comprehensive talk. Really appreciate it. And if you have any questions, please feel free to put it in the chat or unmute yourselves. I don't see any. Only Finbar. Finbar has a question. Go ahead, Finbar. You can unmute yourself, actually.
Thank you. Thank you, Lisa. That was a really interesting talk. I wanted to specifically ask about your slide showing the benefit of the addition of auto EPAP to the neuromuscular disease patients.
Yeah.
In particular, I had just been reviewing your highly cited paper on NIV in neuromuscular disease and kind of the highlight of the benefit of a lower EPAP, often 4, and sometimes talk about newer devices go down as low as 2. And obviously, we only get the auto EPAP in event, and there are certain benefits to having a RAD in this population, you know, rent to own, and we can kind of remote monitor and remote change. So how do you decide when adding auto EPAP is appropriate and changing devices, et cetera, since it's not an easy thing to do, and there's a physiologic benefit to the lower EPAP?
So what I would say is that you're absolutely right. If we could get all the benefits of a RAD in terms of cost and everything else with auto EPAP, then I would do it, and I would start down at those super low levels, and I would set them between, say, 2 and 6 or 2 and 8 at the most. And if I lived in England, that's what I would do. But unfortunately, because we can't get auto EPAP in the US, then we only engage it if they also qualify for a vent for other purposes. And typically that other purpose is going to be mouthpiece ventilation. So when they're ready enough for mouthpiece ventilation, then we do it. Also, the other thing is that, so 2 specific neuromuscular diseases are going to be more of an issue for the auto EPAP. One is going to be Duchenne muscular dystrophy, because their primary treatment right now is a drug called deflazacort. Deflazacort has a steroid at its core, which causes huge expansion in the posterior pharynx with fat deposition, et cetera. So the auto EPAP is really important there. And then the other time that it becomes important is in patients who are using the auto EPAP at night, but then at daytime, they're still using their mask, right? And so that allows us to get an EPAP up high enough at night that the upper airway stays open, even if it's very low, 4 or 5. And then during the daytime, it can stay down at 2 so that they can use it and still talk. Does that make sense?
Yes, thank you.
Okay, great.
Great, thank you. And I have one comment from Craig Canapari. Well, Lisa, I have to go, but always learn so much from you. And I don't see any other questions. I have a quick question. So for the dyspneic COPD or neuromuscular disease, how often do you use IVAPs? Because, you know, it calculates the total alveolar ventilation. So, you know, if the rate goes up, the tidal volume can be. Could you tell us a little bit?
So we use a lot of IVAPs in patients that are limb onset ALS. So progressing quickly and limb onset in nature. In patients that are bulbar onset in nature, they have trouble with those higher volumes. And so we tend to use them in straight ST. Also in COPD patients who have chronic hypercapnia and have had hospital admissions, they are the ones that need the high intensity pressure support. And it's almost impossible in an American environment to do ST and get high intensity because people don't want to put the IPAPs up higher than 18. But if you do it with a targeted alveolar volume and you target 8 cc's per kilo, you will get to 18 or greater in most of these COPD patients. So that's the time that I would do it. The guys that have combined hypercapnia with hypoxemia and need that high intensity goal.
Thank you. Thank you so much again. I don't see any other questions or any hands raised. Well, we saved the best for the last. So thank you so much again, Dr. Wolfe, and see you all next week for the combined Harvard-Yale conference. Take care, everyone. Bye-bye.
Bye, guys. Good to see you.
Thank you.